It is a great pleasure to introduce Juan Pablo Kaski. Juan Pablo I've known for many, many years, and he's now become, I think, one of the major leading lights in pediatric cardiomyopathy. When I think back when we started, pediatric cardiomyopathy was seen as a sort of a rare, slightly esoteric area. The few cases that were identified were felt to be almost hopeless and beyond any form of active treatment. And I think what Juan Pablo has done over recent years is to show that actually, if you take a systematic approach to diagnosis and management, that you can not only make the diagnosis more effectively, but also save lives and improve the quality of life of children with this complex family of diseases. I think Juan Pablo has many different strings to his bow, but perhaps the most important thing he's done in recent years is to develop risk stratification algorithms for children. The insertion of defibrillators in kids with cardiomyopathy is never a small decision to make. And what he and his group have done, I think, have provided us with a more rational, a more systematic approach to identifying those individuals who are most likely to benefit from therapy. The most important thing he continually teaches me is that this is a lifelong disease, because he sees it from its inception. And that's why tonight we've asked him to talk about cardiomyopathies as a lifelong disease. So Juan Pablo, really nice to see you here, and we're really looking forward to your lecture.
Fantastic. Thank you, Terry, so much for your kind introduction, and thank you also to the organizers for inviting me. It's a real honor to be able to give one of the opening lectures of what promises to be a truly fantastic few days. So when we think about lifelong disease, often there's a tendency to focus on this end of the spectrum, so how a disease progresses over time, how it affects older individuals. But what I'd like to do is shift the focus a little bit towards the younger age group and the sort of early spectrum of this lifelong group of diseases. And in particular, I'd like to maybe address some of the chasms that perhaps have developed in terms of our understanding of pediatric cardiomyopathies in the context of the much larger group of adult disease. And in that process, hopefully debunk some of the myths that have evolved over the last few years in relation to this. And what I'll try and do over the next 15 or 20 minutes is focus on some aspects of diagnosis, of screening, and of clinical management. So these are the cardiomyopathies, and as we'll hear throughout the course of the next 3 days, the definition and classification of the cardiomyopathy, at least as it currently stands, is based primarily on its morphological description. So you have hearts that are thick, that we term hypertrophic cardiomyopathy, a dilated, poorly functioning hearts that are dilated cardiomyopathy, and so on. But it's important to remember that these in themselves are not actual diagnoses. It's the first step in the diagnostic process, diagnostic pathway, but it's truly a morphological description. So what we then have to do is divide these conditions into familial or genetic, or non-familial, non-genetic causes, and then still further to try to identify each specific disease subtype. And this is particularly important, I think, in pediatric cardiomyopathies. We know that the etiology of cardiomyopathies in childhood is extremely heterogeneous. These are data from a UK national cohort that we published a couple of years ago, where we found that whilst most children with hypertrophic cardiomyopathy have what we called idiopathic disease, this is primarily sarcomeric disease, there's still an important minority of patients with secondary causes, other causes, so malformation syndromes, particularly Noonan syndrome and other related retinopathies, metabolic disease, and neuromuscular syndromes. And these are particularly important in the first 2 years of life. That's where their prevalence is highest. But it's important to recognize that actually these diseases occur across the lifespan of individuals, and we can make the diagnosis of some of these very rare diseases later on in life. And here's an example of the sort of thing that we're talking about, and the sort of thing that Perry alluded to in his introduction. So this is a patient of ours, a boy who presents at the age of 4 months with symptoms of heart failure, born of consanguineous parents, an extremely abnormal ECG, gross voltage criteria for ventricular hypertrophy and repolarization abnormalities, and an echocardiogram that shows truly extremely severe left and right ventricular hypertrophy. In a case like this, you don't really need genetic testing or any fancy tools to make the diagnosis. This is an example of Pompe disease. And it's important to make these diagnoses and identify these patients because we know that the prognosis is different in these children. So we know, again, data from our UK cohort, that children diagnosed in the first 2 years of life have a worse prognosis than those diagnosed at a later stage. And also that is partly driven by the underlying etiology. So inborn errors of metabolism, like Pompe's disease, tend to have a much worse prognosis than some of the other etiologies. But if we focus more on that group in infancy, and these are data from a multi-center study involving a number of centers in Europe that we published just a few months ago, what we find is that whilst it is the case that those children with metabolic cardiomyopathies tend to have a worse prognosis, actually in all the etiologies, most of the attrition happens in those first 2 years. And those children that survive those first 2 years actually do very well. So most of the deaths are happening in that period of infancy across all etiologies. And importantly, the most common cause of death in many of these patients, particularly those with rhizopathies and metabolic disease, are non-cardiac causes of death. So it's really important to identify these children because the treatment focus will be very, very different. What's also interesting from this cohort is that although genetic testing has increased in more recent eras, even in infants with hypertrophic cardiomyopathy, what we're finding is that there's a substantial proportion of infants diagnosed with hypertrophic cardiomyopathy who have sarcomeric disease, have non-syndromic disease. This concept that infantile disease, for example, is a very different group of conditions to adult cardiomyopathies may not be perhaps as true as we once thought. It matters to identify these patients also because the treatments might be different. So we've been practicing precision medicine in pediatric cardiology for many, many years. We know that treatment with enzyme replacement therapy, for example, reduces the degree of left ventricular hypertrophy in children with Pompe disease. And more recently, there are data emerging that treatment with MEK inhibitors might also do something similar in very sick infants with Noonan syndrome. So still data to be acquired here. So that was all hypertrophic cardiomyopathy. We see a very similar pattern in dilated cardiomyopathy, extremely heterogeneous group of conditions in the pediatric population. And again, important to identify the different etiologies because the prognosis, the outcomes are different. These are data from a pediatric cardiomyopathy registry. And what's striking is that much like our hypertrophic cardiomyopathy cohort, most cases are apparently idiopathic. There are important minorities of myocarditis as a cause, but in this cohort, only 5% of the children included in this study had evidence of familial disease. And so this leads to that first paradigm or myth that I'd like to debunk, and that's that familial genetic disease is actually uncommon in pediatric cardiomyopathies. Now, we know that's not the case. Many years ago, we showed that in pre-adolescent children with hypertrophic cardiomyopathy, familial disease is present in over 60% of cases, and in over 50%, we identified mutations in the cardiac sarcomere protein genes, same mutations that cause disease in adults. And that's across all age groups, with the exception of that first year of life. But as I've already shown, even an important proportion of those patients also do have sarcomeric disease. And we're beginning to see something similar with the other cardiomyopathy subtypes, so data from whole exome sequencing suggesting a yield of genetic testing of up to 50% in childhood DCM, the usual suspects, same sort of genes that cause disease in adults, and similar findings now emerging with the arrhythmogenic cardiomyopathy group. And these are data from the European Pediatric Cardiomyopathy Myocarditis Registry that we presented at the ESC Congress a couple of years ago, but really showing the same thing. So a high prevalence of familial disease across all age groups, across all subtypes of cardiomyopathy, and a very high yield of genetic testing. So over 70%, for example, in children with hypertrophic cardiomyopathy. And similar data now emerging from the Pediatric Cardiomyopathy Registry published earlier this year. So this idea that genetic disease, that familial disease is rare in childhood is really not the case. Now, this leads to another question. Can we use genetic testing to help us diagnose pediatric cardiomyopathies? So here's an example. This is a patient referred to us following the diagnosis of hypertrophic cardiomyopathy in his father. His father has a well-recognized pathogenic mutation in troponin T. And these are the investigations in our patient. So this boy is 14 years old at the time. He has a slightly abnormal repolarization on his resting ECG, but no evidence of left ventricular hypertrophy on echo or cardiac MRI. But on 24-hour monitoring, we find evidence of non-sustained ventricular tachycardia. When we go back and perform predictive genetic testing, we confirm that this boy also carries the familial troponin T variant. So does this child have hypertrophic cardiomyopathy? So he doesn't have left ventricular hypertrophy, but actually there are features here of the phenotype of hypertrophic cardiomyopathy. I think this is important because it highlights the necessity to not focus on a single parameter when we're identifying disease, particularly in relatives. And this leads really to the second paradigm or myth that I'd like to debunk. And that's this concept that when it's not that super rare stuff like Pompei's disease that I showed you earlier on, if it's not that sort of stuff, then actually pediatric cardiomyopathies are just very mild, very early forms of adult disease, and so nothing much to worry about. So here's another example. This is a patient with a very strong family history of hypertrophic cardiomyopathy caused by a very well-recognized mutation in the beta-myosin heavy chain gene, a number of sudden cardiac deaths in the family, a number of heart failure-related deaths. And this is the phenotype of this patient at the age of 11. So severe left ventricular hypertrophy, substantial scarring on cardiac MRI. This is not mild disease. And in fact, when we look at our cohort of children with beta-myosin heavy chain mutations, primarily relatives who referred for family screening rather than probands, diagnosed across a whole age spectrum, but importantly, many diagnosed in that first year of life. These children have very severe disease. These are maximal wall thickness Z scores, 3% present with out-of-hospital cardiac arrest. But what's interesting is that in this cohort, yes, we have appropriate ICD therapies and some sudden cardiac deaths, though actually not many at all. What's remarkable is that in this cohort, there's a relatively high prevalence of cardiac transplantation and heart failure-related morbidity and mortality. And this is in contrast to what we see with myosin-binding protein C mutations. So these are data, again, published very recently, looking at over 60 children with MYBPC3 variants. In this case, again, diagnosis very early on in life, 40% due to family history, the others incidentally or due to symptoms. But 10% of these patients presented with an out-of-hospital cardiac arrest. And the prognosis for these patients is really very poor. It's really a high prevalence of arrhythmic disease that we're seeing in these patients. And importantly, whether you're a proband or a relative doesn't seem to make much difference in terms of the prognosis for these C protein patients. So potentially some genotype-phenotype correlations that are worth exploring here. And I think this leads nicely on to the next aspect that I'd like to discuss, which is the issue of family screening. So current guidelines for clinical and genetic testing in relatives of individuals with hypertrophic cardiomyopathy recommend cascade screening as a class 1 indication, but not in childhood. So in childhood, the current European guidelines don't recommend starting screening below the age of 10. The American guidelines until the most recent iteration were very similar. The only difference is that they recommended starting screening routinely from the age of 12 onwards. This is based on what is available in the literature. So I've already shown you with DCM, but it's the same with hypertrophic cardiomyopathy. Familial disease very rarely reported in the pediatric literature. There are also data from a study from Barry Maron's group in the 1980s that suggested that in familial disease, left ventricular hypertrophy doesn't tend to develop until adolescence or later. More recently, data from a Danish group suggesting that the penetrance of sarcomeric disease was extremely low in the pediatric population. So this is what those guidelines and recommendations are based on. And this leads to this paradigm that actually there's no need to screen for cardiomyopathies in childhood because it doesn't exist, doesn't happen. The problem is that if you don't look, you won't find. So if we look at Barry Maron's paper, what you find is that, first of all, there are very few children below the age of 10 included in this study, but those that are already have evidence of left ventricular hypertrophy. So they already had a diagnosis of hypertrophic cardiomyopathy. And yes, the absolute values for wall thickness increase with age, as you'd expect, but they already had HCM. And with the penetrance study, actually, there are very, very few children included in this study in the first place. So difficult to draw meaningful conclusions. But this is different to what we have seen in our own practice. And we published this in Circulation in 2019. And this was our experience of screening pediatric first-degree relatives for hypertrophic cardiomyopathy, so nearly 1,200 patients from nearly 600 families. And what we found was that in nearly 10% of these families, we were able to make a diagnosis, a clinical diagnosis of hypertrophic cardiomyopathy. And that diagnosis was made at all ages, but including a very substantial proportion of patients diagnosed very early on in life. In fact, the median age of diagnosis in this group was 10, 80% diagnosed below the age of 12, often in that first visit. And importantly, the diagnosis results in a change in management in over a third of these patients. And if we just follow the prevailing European, North American guidelines, we would have missed the opportunity potentially to make a difference to a huge chunk of these children's lives. What we were also able to show, and these are data from Max Lorenzini and Perry Elliott together with our group, was that the penetrance of sarcomeric disease in this cohort, a much larger study, is around 50% at 15 years. And importantly, that is the case regardless of the age at which you're screening. So if there's an argument to be made that clinical screening and genetic screening is worthwhile, then actually there's nothing to suggest an age cutoff for that. There may be other things like ECG changes that might be useful to guide which patients might benefit more from clinical screening, but certainly age should not be one of those. Now, of course, we don't want to create more problems when they're there, and so it's really important that all of this clinical and genetic screening happens in the context of a multidisciplinary, holistic center, and we have shown that in that context, actually clinical screening and genetic diagnosis does not affect the psychosocial performance or scores of the children that we see in our clinics. And actually, there's very interesting data emerging from the Pediatric Cardiomyopathy Registry in the States to suggest that teenagers in particular actually want to know, they want to be screened, they want to receive the genetic information, and often they want to receive it at the same time as their parents. And so as a result of all of this, the most recent iteration of the American Hypertrophic Cardiomyopathy guidelines have now changed. They've removed that lower age limit and now recommends clinical screening at any age, and certainly not after puberty. Now, in terms of management, and this is hypertrophic cardiomyopathy, but actually the same applies to all the cardiomyopathy subtypes. The focus really for years, as Perry mentioned, has been on prevention of complications, so sudden cardiac death, stroke, atrial fibrillation, heart failure, and empirically on treatment of symptoms. Now, focusing on sudden cardiac death, this is again data on hypertrophic cardiomyopathy, but the same sort of thing applies to the other cardiomyopathy subtypes. There are multiple triggers for ventricular arrhythmias in hypertrophic cardiomyopathy. And some of the early studies suggested that these were diseases that were associated with a high degree of lethality, so sudden death rates of up to 10% per year in some series. The more recent population-based studies, PCMR data, our own UK cohort, suggest that actually the outcome is much better than that. Sudden death rates in the region of 1.2 to 1.5% per year, so much, much lower than previously thought, but still about 50% higher than what we see in adult populations. We know that Icd implantation is effective at reducing the risk of sudden cardiac death, both for secondary prevention and for primary prevention in children with hypertrophic cardiomyopathy. But we also know that this comes at the expense of significant complications. So again, these are data from our UK cohort, but 21% had complications, and these were primarily related to lead issues, but also to infection. And this is beyond the scope of the study, but there's a move in recent eras towards implanting simpler devices, subcutaneous devices, single chamber devices. So really important actually to identify those children who are most at risk and who would most benefit from implantation of an ICD. The current guidelines for children are really extrapolated from adult data. So European guidelines recommend ICD implantation in the presence of 2 or more of the so-called conventional risk factors: severe LVH, unexplained syncope, non-sustained VT, family history of sudden cardiac death. The American guidelines, including the most recent guidelines, use a very similar approach, a cumulative risk factor approach. The only difference being that in the States, you just need one of those so-called conventional risk factors to warrant an ICD. And this is the paradigm that actually sudden death risk in children can be assessed just by extrapolating what we know about adults. Now, again, we showed that this isn't the case. Again, using our UK cohorts, what we found was that whilst it's true that those children with increasing number of risk factors do have a higher risk of sudden cardiac death, most children who died suddenly or had an event actually had only one, or in many cases, none of those conventional risk factors. And the performance of this approach is a little better than random, but really not much more so than that. See statistics of 0.6, 0.62 for the European and the American approach. And so in order to address this issue, this gap in knowledge, a few years ago, we established an international pediatric hypertrophic cardiomyopathy consortium. Now consists of data from over 45 centers and over 1,700 children. And we used this to develop and validate the first prediction model specifically for children with hypertrophic cardiomyopathy. And this was published a couple of years ago. And we used parameters that we identified from the relatively limited literature, but these were risk factors that were associated with sudden cardiac death in the literature: maximal wall thickness, left atrial diameter, importantly as continuous variables, but also corrected for body size, which is important in a pediatric population. Unexplained syncope, non-sustained VT, and left ventricular outflow tract obstruction. And using this, we were able to develop a model that, on our internal validation, accurately predicted those at highest risk of sudden cardiac death, with a good C statistic and a good calibration slope, very similar to the adult models. Since then, there have been two very small external validation studies, one with 78 patients from Poland, one with 100 patients from Sweden, but both suggesting that this is a better approach than the current recommendations. And we have also completed our own external validation using a completely independent group of patients, including patients from the SHARE registry. And again, we're able to show that this model performs well. And although we didn't set out to identify a specific threshold, using 6%, which is the same threshold that's used in adults, seems to be the most accurate way of predicting sudden cardiac death in this population. But of course, the importance of these models is to allow shared decision making between professionals and families. There's another model that was published after ours from the Toronto group that used a slightly different approach to risk factor identification. It was a much smaller cohort, but actually the risk factors that were identified are very, very similar, and the performance of both models seems to be quite similar also. So I think we now have a much more accurate way of predicting sudden cardiac death in children with hypertrophic cardiomyopathy, but there are, of course, important gaps of knowledge that still remain. So first of all, we need to externally validate this in a real world situation. And so in order to do that, we've made our model widely available, freely available on the internet. We know that hypertrophic cardiomyopathy is an evolving phenotype, particularly so during childhood. And so it'll be really important to validate this model using serial data and to incorporate that into future iterations. Important also to assess additional risk factors. We looked at whether the addition of an ECG risk score was able to refine the model. In our experience, it didn't. Some data from the Polish study suggesting that perhaps the addition of late GAD enhancement to our risk model improves its performance a little bit, but these are very early days and we'll need to look at this in more detail. Everything I've talked to you about in relation to risk relates to non-sarcomeric disease, but we know that although it's much rarer, children with vasopathy syndromes, metabolic disease, can also die suddenly. And so identifying specific risk factors for those groups will be extremely important. We'll need to assess the relationship of individual risk factors with sudden cardiac death in more detail, and particularly left ventricular outflow tract obstruction, which appears to have a slightly different relationship to sudden death compared to adults. And finally, I think it's really important to remember that although we're focusing on sudden cardiac death because that is the most common mode of death in childhood, actually hypertrophic cardiomyopathy is really a disease of heart failure longer term. And these are really elegant data from the SHARE registry published earlier this year, showing a substantial lifelong morbidity that's actually more related to heart failure and atrial fibrillation in individuals with childhood onset disease. So coming back to this issue of lifelong morbidity and these being a group of diseases that affect individuals of all ages, these are data that we presented at the EST earlier this year, looking specifically at children diagnosed under the age of 12. And what we were able to show was that the outcomes, the natural history curve, appears to be shifted to the left. So it's the same disease that we're seeing in the older children, but the events are happening much, much earlier. And this is also what we see in adults with hypertrophic cardiomyopathy. Again, data from the SHARE registry showing that those with an earlier age of diagnosis have a substantially longer period of lifelong morbidity. And so when we're thinking about treatments, and Perry, you touched on this earlier on, it's really important to have a look at whether we can now start to modify the disease process itself. And Perry's already mentioned this. There are new drugs that are now emerging that do this. They target the underlying pathophysiology. So the example of mavacamten, a myosin inhibitor in adults with symptomatic left ventricular outflow tract obstruction. More recently, the trial of aficamten that the Redwood HCM trial reported, also showing very promising findings. For me, what's really exciting about these class of drugs is that in the preclinical model, in the mouse model, these drugs appear to prevent the development of left ventricular hypertrophy. And as Perry also mentioned, there are now programs related to gene therapy that are also targeting children and neonates with hypertrophic and other cardiomyopathies. And so I think we're entering a really exciting era. And really, when we think about lifelong disease, we have to start from the very, very beginning and those children who develop these diseases. So in pediatric practice, we have cohorts of preclinical patients, patients with early disease, patients with overt disease, all the way through to severe phenotypic expression. And these all represent important opportunities for intervention. So thank you very much indeed. I just want to thank all of the investigators from the UK Pediatric Open investigators and the International Pediatric Hypertrophic Cardiomyopathy Consortium for contributing and collaborating with us in much of the work that I showed today. Thank you very much.